Welcome to another episode of Key into Quality, a Mayo Clinic podcast focusing on healthcare quality and experience trends and solutions. I'm Dr. Tim Morgenthaler, a professor of medicine at the Mayo Clinic and vice chair of Mayo Clinic Quality. Today's episode is special. It's a bit different. We're joined by three amazing guests, two from Yale and one from University of Kansas, who are leading a national project aimed at making sepsis care not just better, but less biased. As always, our co-host today is Sherry Nemec. Sherry, say hi.
Well, hello to all our listeners. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. Dr. Morgenthaler, you mentioned the condition sepsis in your opening. And for those that are listening, maybe they might not be aware of what it is, but sepsis, in simple terms, is a life-threatening emergency that occurs when your body's response to an infection damages vital organs. And according to the CDC in the US, 1.7 million, yes, million people develop sepsis, and at least 350,000 adults die from sepsis every year.
Yeah. Yeah. So this is a really important topic. And because of that, I've invited really important guests. And I have to tell you, I was looking at their credentials, and if I read all their credentials, we would be done with the podcast before I could finish. So instead, I'm just going to say, I'm going to ask them to each just give a little bit of information about themselves. But joining us today are Dr. Erica Linander, Dr. Leslie Curry, and Dr. Steve Simpson. They are part of an initiative that's called the CARES Initiative, and they'll explain that for us later. But it's a collaborative effort working with hospitals and communities to try to reduce racial inequities in how sepsis is recognized, treated, and followed up afterwards. The project really is responding to longstanding observations published all over the place in black and white that find that Black and Latinx patients are much more likely to receive either delays in their care, lower quality care, and flat out are more likely to die from sepsis. So this is something we should all care about. The Sepsis Alliance, which is the nation's first and leading sepsis organization, has really emphasized the urgency of addressing racial inequities in sepsis care in particular, prioritizing this in its mission. So there's some Mayo Clinic Care Network sites that are involved in this initiative, but this conversation really is for all of our listeners. It's for anyone who cares about quality, equity, meaningful change in healthcare. So I'm really excited. Let's get started. As I mentioned, we have these distinguished guests here. Dr. Erica Linander, she directs the Yale Global Health Leadership Initiative and leads the CARES intervention team. Dr. Leslie Curry is a professor and national expert on how leadership and organizational culture affect health outcomes. And Dr. Steve Simpson was actually prior president of the American College of Chest Physicians, and he's a professor of medicine at University of Kansas, longtime leader in critical care and sepsis research, and he serves on the advisory board for the CARES project and chairs the board of the Sepsis Alliance. So a lot of mouthful there, but I'm going to just lead off with a question. Maybe I'll address first Dr. Simpson. Just tell us a tiny bit about yourself, and then tell us how you got first started in this particular problem. What got you revved up for it?
Yeah, I'll start by saying the first part started historically when I was a kid growing up. I grew up in the Mississippi Delta. I was in the seventh grade when we integrated the schools in Mississippi and was totally appalled at the reaction of some of my classmates when that happened and what their parents did and what they said. And so I firmly believe in equity for everyone. I always have, and that troubled me then. It continued to trouble me. Later on, when I got to be a young doctor, when I was an intern at the University of Kansas many, many years ago, I encountered the first person where I thought, I wonder if this person has sepsis. And at the time, October of 1983, I had no way of knowing because there were no criteria. I went and trained with the guy who developed the sepsis criteria. His name was Roger Bone, and have worked in this area ever since. So how I got to this particular thing, several things came together all at once. One was we did a machine learning study in our emergency department where we looked at 25,000 people with suspected sepsis to see what does a doctor see in the chart that makes them treat people more rapidly. And the thing that we found was that one of the things that made them treat people more slowly was if you were any color other than white. This is really weird because I know these guys in our emergency department. Some of them are themselves people of color. I know they're not trying to do this. They don't mean to do this. I don't know what to make of this. Then I start reading the literature and I find out that if you're a white kid, I'll say it this way, you're 3 times as likely to get the sepsis pathways activated when you show up in the emergency department. If you're Black, in numerous studies, you're at least 20% less likely to get those things done, even if you're an adult. As far as sepsis outcomes, it's not as clear, but as far as readmissions, it's clear. You're 20% more likely to have a readmission for sepsis if you are Black or Hispanic white than if you're white. And so this was troubling. And you mentioned I was president of the American College of Chest Physicians. This all was coalescing in my mind as I took that presidency, and I made it a part of my presidency to get chest at least oriented towards equity.
To me, when I hear that, and I can just imagine you seeing these data come together, I would say, oh my gosh, this is terribly exciting as a researcher, because here's a gap that we should be able to find an explanation for and make things better. And on the other hand, when you start thinking through the root causes, it can get a little scary, because then you're going to start looking at inside of our hearts, perhaps, and not in the cardiologic sense. So what did you find as you started taking that on? Were there pathways clear and so forth, or what did you think?
No, this has not been well defined yet. And that's part of why Leslie and Erica are involved here, is that we don't know for sure the reasons. But one of the things we discovered while I was with CHEST is that we did a series of listening groups across the country, places like Jackson, Mississippi, San Antonio, Texas, Los Angeles, various different places around the country. And one of the things we learned is that people of color don't really trust their doctors when they show up to the emergency room. And if you don't trust your doctor, you're not likely to tell them exactly everything that's going on with you just right off the bat. Hi, doc. There just is this low level of trust. And sadly, at this point in time, most of the doctors you encounter in an emergency department are white. And so I'm certain that plays into it, but no, it hasn't been completely well defined yet.
Dr. Simpson, thanks for getting us started in this conversation. Dr. Curry, welcome. Is there anything else you would like to share with us about you or your story? And then start to talk about who did you involve as you started to organize this work?
Yeah, sure. Thank you so much. Yeah, as Dr. Morgenthaler said, I'm here at the Yale School of Public Health. I think one feature of the School of Public Health, which has kept me here for a long time, is that we work really deeply collaboratively and with a multidisciplinary lens on kind of all the questions that we want to ask and answer. And so I'm grateful, for that way of working, and that's totally imprinted here on this CARES project. Who did we involve? Always a village. Yeah. So I would say maybe 3 primary groups in addition to our really diverse set of colleagues here at GHLI. First, of course, couldn't have done anything without the NIH funding. And at the time when we submitted this grant, at least then,
We'll
NIH
come back
had
to that.
an explicit, yeah, or maybe we edit that. I don't know. At the time, NIH had an explicit commitment to equity and calls for proposals for research that would address race-based inequities. I will say, this was a surprise to all of us. We submitted this grant and it was funded on the first go. Unusual. And I think a signal of sort of the national interest and the prioritization of this whole arena of work as being a priority. So got the funding. The national partners that we always will partner with in terms of credible organizations that are influencers in the space where we're working. And that's, of course, our friends here at the Mayo Clinic Care Network. We've collaborated in the past, as you know, really successfully on other work related to AMI care, so care for patients with heart attacks. And we came in that work and also in this study to NCCN because we really do see the network as really a signal of organizations that are kind of early adopters of innovations and quality, sort of way out front, willing to invest resources, time, energy in innovation and quality improvement, And then B, maybe even more importantly, this kind of learning collaborative, so they're eager to learn from others. And with us, we sort of put on our science hats, and that's just one piece of the picture. The science really doesn't matter at all if you can't partner with providers who are actually going to make the changes and do better for patients. So 2 was MCCN. And then last was we're very intentional about the teams we build. Erica can talk more about this in terms of her leadership and intervention designs, but knowing that we certainly don't have all the expertise we needed. So this is how we built out a national advisory board that includes Dr. Simpson, thankfully, who said yes when we reached out to him, and others with expertise in community-based participatory work, other kinds of dimensions of sepsis care and quality that we needed expertise, in. So it really does take a village, and grateful to all the partners for coming to the table for this work.
Well, Dr. Linander, so the CARES network or the CARES project, it sounds like an acronym. It probably is. Tell us what it is and give us the background about this. Tell us first about yourself. Welcome to our show.
Thank you. Thanks for the opportunity to talk about this work and to share it with your listeners. Yeah, so our team at the Global Health Leadership Initiative, we focus on management, leadership, and organizational performance as leverage points to achieving all kinds of public health and clinical outcomes. The best parts of our work come when we're faced with a clinical or a public health outcome that seems sort of intractable, sort of hard to get your hands around. And so we figure, okay, that's a complex challenge. And how do we bring principles of leadership and principles of organizational performance to bear on what seems like a very highly technical, in this case, highly technical clinical challenge of sepsis and specifically of sepsis inequities. And so our team, Leslie and others, had done, decades of background research that led into the CARES effort, first starting with AMI care, as Leslie described. And what that work showed was that organizational culture is essential in changing complex health outcomes. So strong evidence base that organizational culture matters for clinical outcomes. And importantly, organizational culture can be changed through leadership interventions. And so this is a thing that we actually have science on. It's not fuzzy. Sometimes people think organizational culture, oh, that's sort of this fuzzy thing over here, but there's strong science to say that organizational culture can be changed through a couple of ingredients. And so that's how CARES evolved. As Dr. Simpson described, structural racism is a complex issue. Structural racism is not just how one person gets treated by another person. It's this amalgamation of all of these different factors. You talked about, early experiences with integration of education systems. We talk about access to healthcare. We talk about housing. We talk about all the different ways that structural discrimination shows up in our environment, in our country. And so we've got the complexities of structural racism, got the complexities of sepsis, which is a highly complex clinical phenomenon. Bring those two together. So the question then becomes, how do we equip health systems to unpack this complexity in a way that lets them get traction? So you started with a really simple question. Is CARES an acronym? Yes, CARES is an acronym. It stands for Champions Advancing Racial Equity in Sepsis. And that's what this work takes, are champions that are going to come to the table and say, we don't really know what this is, but we're going to figure it out. We're going to put together a structured process to figure this out. And so CARES has 3 aims. The first aim, which I'm responsible for, is to deliver we call it a coalition-based leadership intervention. We've got 3 amazing health systems who have signed on to this. They're our early adopters. And within each of those systems, they've put together what we're calling guiding coalitions, which are teams of 8 to 10 individuals from across the health system, all of whom have influence in different ways on sepsis care and sepsis quality. So that's aim 1, deliver the intervention. Aim 2 is to evaluate the effects of that intervention on domains of organizational culture that we hypothesize to be foundational for doing anti-racist work. So things like, how do you build leadership support for this effort? How do you build psychological safety, the space and the place for people to have courageous conversations? Things like, how do you put together strategic planning processes to support organizational change efforts? So those are these domains of organizational culture. Leslie and crew are responsible for using a mixed methods approach to evaluate change in those domains of organizational culture over time. And then the third aim of CARES is to see if we can demonstrate change in those aspects of organizational culture do we see reduction in inequities in sepsis care and outcomes? We have 3 clinical outcomes associated with that. Number 1 is time to treatment. Number 2 is in-hospital mortality. And number 3 is 30-day all-cause readmissions. So do we actually see benefit, direct benefit, to patients surviving sepsis?
So kind of the 3 aims are the who, the how, and the so what.
And the so what? That's right. That's right.
Yeah. Yeah. I'm curious, I know you've spoken already about how it is that you chose Mayo Clinic Care Network members, but you visited those sites, I know, and engaged in some conversations. You mentioned the word champions. As someone who's helping to lead these interventions and these efforts, how do you choose or recognize your champions? I think this is a general question for all quality improvement efforts. It's like, how do you begin to think who are going to be the champions for your change?
I think that's such a fun and important process. We start this work through role-based recruitment. If we think about the pathway of care for a patient with sepsis, we think about all of the roles within the health system that have to come together to influence that care. We identify those by department, by discipline, and so we have sort of a starter list of roles that we think would be important to have at the table. But we're coming in from the outside. We don't know these people. And so we work with the health system to say, here's how we would do it. But what do you think? Given your organizational structure, given the individuals in those roles, who do you think should be at this table? And so there's that kind of back and forth evolution of the coalition membership. And that's actually in our prior work, we saw that intentional evolution of coalition membership was a marker of highly successful coalitions. We got to bring on kind of a young, fiery newcomer to this, or, oh boy, we better get endorsement from our, very long-standing senior CMO or whatever it is. So I think that's a dynamic process that we manage very intentionally.
I want to go deeper into the rest of the project, but just on this point about recruiting champions or identifying them, again, I always kind of look at these situations and say, this is really exciting because you're now offering an opportunity for people to really develop their leadership skills and their careers that might not otherwise have been there. So, I always kind of look to see, well, who's raising their hands and who's leaning in, because those are people who want to grow. And I just think those are the exciting people to work with.
Yeah, I totally agree. And even in these times of stress and chaos and burnout, right? Meaning and purpose and being able to actually do something about your why, bringing those people together to make a difference is so impactful. I want to jump over to Dr. Curry again. So you've got this going. What have you learned so far?
Yeah, we're already seeing promising signs of impact in multiple ways. We've been out now in the field for 2.5 years. So I'll just describe kind of high level some of the things that we're seeing that are really quite promising. First, many health systems are talking about equity, commitments to equity, kind of at a theoretical level, but have not had the opportunity to really point to a concrete effort. What does it mean to really address inequities in clinical care and outcomes? And so the systems are able to point to this initiative, to CARES, as a concrete example of the kind of work that can be done. So moving from the theory into the practice is something that I think that the sites are really feeling really empowered by. Second, the sites have dug really deeply into their race, ethnicity, and language data, and really challenging in all settings, I think, nationally, to have robust race, ethnicity, and language data sets. And so they're working really hard to strengthen those systems for data collection and for analysis. 3, I think we appreciate the sites are very mindful of the local context and talking about systemic racism and racial inequities in really powerful language and framing that is appropriate for their context. And this is really just so important. And so we're seeing the sites think about what is the goal? It's best care for all, as sort of one example. It's really interesting to watch that unfold. And then last, maybe I mentioned, we're watching the teams begin to work in different ways, paying attention to power dynamics, understanding that conflict can be a good thing. These are all the sort of ways of working that Erica and her team are coaching on, bringing people to the table that aren't normally at the table. So you asked Dr. Morgenthaler, who are the champions? unlikely characters in some instances. And so the coalitions that the sites have built out and that Erica is working with and Steve place maybe a chief executive next to a frontline nurse who's doing clinical bedside work. And together they're identifying, naming problems and developing solutions. And so this is sort of a transferable way of working. In our past work, we've seen hospitals begin to use that sort of model of work, saying, my gosh, we could do this to address, challenges in stroke care or in population health. Maybe there's one more that I would add in terms of what we're learning so far. The sites really are beginning to think more broadly about sepsis. So sort of beyond the specific clinical pieces to think about broader aspects of sepsis care. So what's happening outside the hospital walls? What's happening in the community before people present to the emergency department? What's happening to them when they're discharged and go back to the community? And this too, I think, is really, a new lens that the sites will be able to bring to any other challenging issue in their population that they want to tackle. So lots of good stuff that we're learning along the way.
I have to imagine that part of the work for a given organization is, first and foremost, and I know because I've been part of some of these discussions, is finding the data, because the data are only maturing, I'll just say, in more recent years. I'll share something that is analogous, but Mayo Clinic has been collecting race and diversity data for a long time. Not a long time, but long time. And just only recently, we were asked, hey, for people who come from other countries and receive their care inside of a Mayo Clinic facility, what did their quality outcomes look like that's different? And we learned there were all kinds of barriers in actually putting those reports together that we did not anticipate. Some of them were concerns about certain laws related to privacy and kind of working our way through those. And some of them were complexity involved with expatriates. They're drawing Medicare. Are they truly international or not? But my point, in bringing all that up is they wrestled with the data, but most of those participating organizations now have data, and they probably are seeing differences in processes and perhaps in outcomes. I'm sure they're not all finding the same thing. Do you have any examples to share with us for, we learned that we are not doing this within our walls correctly? Because I know they're reaching outside now, but inside the walls, what are you seeing are kind of common learnings?
Yeah, I'm going to punt this one to Erica because she's working so deeply with the sites. And Steve, you've been on multiple site visits, to maybe give an example about how they're beginning to tackle this, which is going to have, implications for equity work going forward. So it really is foundational to get it right.
I appreciate your example, Dr. Morgenthaler. One thing we're finding is that the clinical quality pillar in a lot of organizations and the health equity pillar in a lot of organizations are a bit disconnected, structurally disconnected. And so nuts and bolts, who has which data sets? Can you bring those together? Who sets priorities for those various groups? And so, I think that health equity in many systems has sat as it's a value, but it's been operationalized oftentimes in a special committee or a special office off to the side. And so really bringing the capacity or strengthening the capacity of clinical quality programs to include health equity. When we think about when we go back to the definition of quality, equity is in there, but I think most quality departments are not fully operationalizing equity or holding it close, making it part of their own work. So I think that's one really important shift that we're seeing. We're saying, oh, we've got it's all fragmented. How do we bring it together? You mentioned what changes are we seeing, or what are sites learning, discovering about themselves, within their hospital walls. We know that for quality efforts, we can't just look at average performance. And so sites are now saying, well, maybe on average, we're not sure where some of the inequities are sort of hidden, or they don't jump out at you. But when they start to look at who are our outlier patients, who are our patients who have longer times to treatment, or groups that have, higher risk of mortality or higher mortality rates, they are starting to dig in and see either racial and ethnic inequities, or I think equally important, starting to look at other types of inequities as well. And so looking at, is it inequity based on social determinants of health? Is it inequity based on zip code? Is it inequity based on payer, based on all of these other drivers? And so, we went in, our focus, the focus of our little narrow study is on race-based inequities, which is still really, really important. But the participating health systems are saying, yes, and we want to look at all of these other drivers as well.
When they shine the light in the corner, you see what you were looking for, but you see other things too.
You see all those other things. One thing we're learning also is that there's such a big and important push to systematically collect information on social drivers of health. Big work across CDC and others to require the collection of that SDOH data. And I think that is going to be such a rich investment, especially in the current political climate where looking for race-based inequities has become a bit taboo. There still is support for looking for inequities based on social drivers of health. That's something that both political parties can get behind. And so I think that having those data sets will allow us to still look for and address inequities in the current climate.
What do you think are the next steps in this project? Where are you going from where you're at? Dr. Linander.
Our current priority is continuing to work with the sites. We've got about 6 months left on the intervention. And so they continue to work to identify really concrete interventions that can improve sepsis care for groups where we see a gap, but also sepsis care overall. So they're working on building support for standard order sets, strengthening communication, looking at transitions across departments, all of those really, really important things. From our research perspective, we've got, our team here at GHLI is also now starting to look at opportunities to understand the role of neighborhood level factors on sepsis care and outcomes. And so, this CARES work is we tend to think organizationally, right? We're not looking at care for individual patients, although that is very, very important. So in CARES, we're looking at what's the capacity of an organization to address inequities. In our next level work, we're looking at what is the effect of neighborhood level factors on sepsis outcomes and how might assets in disadvantaged neighborhoods be leveraged to strengthen sepsis outcomes in other disadvantaged neighborhoods.
Wow.
The thing that sort of took me by surprise and shouldn't have, back on that question about problems, is some of our sites are in states where the state government has dictated what you can and can't say out loud about racial inequities. And I'm not going to call out anybody, but it just has made it hard. So people, while they're struggling with their own issues and their own hospitals' issues, they're struggling with the greater environment around them. And some of our hospitals are in other places where that's not an issue, but that was a problem. One of the things that's tough here, I think, about processes of care is that, first off, sepsis in no hospital in this nation, well, in a few hospitals in this nation, sepsis care is where it needs to be. But in most, it just isn't. And in a lot of hospitals, they have to comply with the SEP1 measure that I won't really go into, but it's a CMS reporting measure. So they're there about complying, but they haven't really got it yet about what a septic patient truly is and how important this is and how high the mortality is, nor even how much it costs them in their own hospital. Sepsis is the most expensive thing that they treat, and most hospitals don't even really recognize that. So we're combining one difficult thing here in this sort of not well-defined entity of sepsis, and then we're trying to combine it with another thing that's sort of not well defined in what is equity and how good are we at equity.
Two tough problems.
These are two really tough problems.
Yeah. I wonder if I can just ask this question of any or all of you. So what worries or concerns are keeping you up at night these days about this project or this concern?
I do want to say, because I think your listeners need to hear this, when these people, Leslie and Erica, started working in acute myocardial infarction, this is the kind of people I'm privileged to work with. When they started working in acute MI, fewer than 10% of the hospitals in the nation with a cath lab could get people into their cath lab and open their arteries in 90 minutes, which was the goal. Fewer than 10%. This was in the late aughts. And because of their work, directly related to their work and the cultural changes that they've done in hospitals, now it's fewer than 10% don't get their patients.
Yeah, wow, which is huge. in
And
terms of outcomes.
imagine the number of lives that have been saved because of that. It's a real privilege to work with these guys.
Well,
I
what
just
would you
can't.
say? No, please go ahead.
Sorry, I just can't not say thank you, Steve. It's really quite mutual. So we're not clinicians on our team, Erica or I, nor I, or others in the team, and the clinical expertise is, of course, essential. So Steve not only brings that, he brings the kind of national leadership gravitas to the work as well. And so, this is just a critical role. We couldn't really function without that role itself, but Steve as the individual in that role is really just a prized colleague, and we're just deeply grateful. I couldn't let that just not go by there, Steve. Exactly. Just one more then before we go to if there's a closing question, just to highlight, I think, the glass half full angle on this. Despite the national political context, despite incredible stresses around all features of the healthcare system and public health system and sort of the moment we're in, the work that Steve referenced around AMI care and that Erica conceptualized and has led in multiple settings really is sort of agnostic to the end goal in some regards. And it's a way of working inside systems that's different. It allows people up and down the food chain, up and down the hierarchy to sit side by side and to come to a common shared understanding of a goal and to use systematic methods to unpack that, to foster conditions in which failure is expected and is actually an asset. And so it really is just a different kind of worldview about how to do better for our patients and communities. And so I am hopeful, and we're seeing signs of this in the data already, that the seeds that we're planting in these sites are ones that will grow sort of regardless of what's happening in the larger context. Maybe I'm Pollyanna, I tend to be, but I kind of wanted to just bring that context.
Yeah, I'm so glad you did.
This might be also on the optimistic side of the spectrum, but the thing that I'm very excited about is that so much of the evidence base on health equity in general, racial equity in general, and especially in sepsis care comes from urban settings. It comes from academic medical centers. It comes from more politically liberal leaning organizations and geographies. And I think what we're seeing in our participating health systems are that this is universal work. This is the work of healthcare. This is the work of caregivers, of people that are drawn to health as a profession. And the language might look a little different. The work might, the way it unfolds might look a little different. But I think that the evidence that our participating health systems are generating will actually be more transferable to most of the hospitals in the country. So, the work that's generated in academic medical centers is really good for academic medical centers. But I think that we're gonna find that the lessons learned, the insights generated by our CARES participants are going to be really transferable across the country. So I'm very excited about that.
Well, and to that end, you've given me the perfect lead. So you're working with 3 Mayo Clinic Care Network members. You're learning lots of things. You're now on a podcast that reaches many, many people. What would you say to an organization that just wants to start work on this area? What would their first step or two be?
Well, I have Leslie and Erica's home phone numbers. I can. No, I think
And we have yours, Steve, so watch it.
So I think with regards to sepsis, that part of it, there's a lot of evidence out there, and there are a number of guidelines, one of which I'm currently working on, the Surviving Sepsis Guidelines new update, and those are constantly being revised upwards. So there are those. There are also federal standards from CMS about what one should be doing for patients with sepsis. So there's a good framework for where to start. I think it's a little bit harder, probably understanding exactly where to start with equity if you want to grow your own program. But I think it really has to begin with if whatever color you are, whatever ethnicity you are, you need to speak with the other people, start it with the people at your own level and find out, how does this feel right here where we are? What do you think about it? Do you think we're doing a good job of equitable care for everyone? Or do you perceive some differences? That's one thing. I think we have to try to understand each other. And I will say to white people, you are going to feel uncomfortable when you start hearing what your friends of color have to say. And you should be prepared for it and you should be open to it because you're not going to like what you hear about yourself, but that's the only way that you are going to change. I have multiple good friends of color who keep me well grounded and constantly discovering more about myself, but I think that's where you have to start.
Fantastic. Any other words of wisdom?
I don't know if it's so wise, but I think on a practical level, where would I start if I were a health system just embarking on this work? I think I would do two things. I would take the quality measures that you're currently committed to, that are on your organizational dashboards, that your senior leadership is used to looking at. Those are probably your pay for performance measures, but take those measures that you're already committed to and look at them by race and ethnicity. Just have the courage to take a look. You may not find anything, but start there. Stratify those outcomes by a combined race and ethnicity variable. The second thing I would do is, I would pull back the curtain and say, how are we collecting our data on race, ethnicity, and language? What's that process like at registration? Is that data any good? Because if we want to understand variations in care, that's foundational. So how are we collecting our race, ethnicity, and language data? And are there opportunities to improve there? Just like there's national resources on sepsis care, there are national resources on collection and use of race, ethnicity, and language data. And then I think I would do the same thing for collection of data on social determinants of health. Who's asking about those? Do we have care management on that? Is it at registration? Is it nursing? Is it at discharge? And then once we screen for that, what are we doing for it? So those would be my three things. Stratify your existing measures, understand your REL data, understand your SDOH data as foundational.
We have to come to the end of our podcast, but we could talk about this for a long time. This has just been fascinating. I just want to express gratitude personally to each of you for taking time to share your views and your expertise, for the pleasure of working with you over these past years, and for what you're doing to advance, the causes of quality care. Just thank you so much for sharing your work and your wisdom. Today's conversation, touched on some pretty powerful ideas: equity, structural racism, anti-racist leadership. And for some of us, those words may feel unfamiliar or, as Steve mentioned, uncomfortable. But, at their heart, I think this work is about something that we certainly can all agree on, and that is making sure every patient gets timely, respectful, high-quality care. So improving sepsis care, or really any care, means being honest about where gaps exist, courageous enough to explore why they persist, and committed enough to change what needs changing. And that's not politics, that's quality, and that's what we are here for. So, and that's also leadership. So thanks again for listening to Mayo Clinic's Key into Quality podcast. We try to highlight some of the first steps in addressing important quality challenges in your organization. Our goal is to improve quality for all patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listen. And you can also follow us on your favorite podcast platform. Let others in your organization know about this podcast so that the information can be spread. And until next time, goodbye.